Thank you very much for the invitation. And the first talk is about cutting edge of TAVR therapy. And I thought, well, maybe all the cardiologists dealing with children most of the time are not that familiar with the technique so I thought I start from some basics before we come to the cutting edge. Now, it has been 20 years that Alain Crébier started with the TAVI program. And it has gone very, very quickly, starting from patients that are not inoperable patients, going further to high-risk patients. Then the first studies, because of promising results, went further down to intermediate-risk patients, and now we are actually going to low-risk patients. There is, of course, some problems with TAVI, the TAVI procedure, in terms of death, strokes, lethal bleeding, new onset of atrial fibrillation. We are definitely a good comparison and even better than surgery. There is, however, still the problem of a higher pacemaker rate and of re-intervention, basically more or less because of paravalvular leakage. So what is the evidence that we can go to really low-risk patients and actually use this method, this technique in younger and younger low-risk patients? And that is in the two valves that are mainly used. It's the core valve Evolute platform from Medtronic or the SAPIEN platform. And these are the two studies that went through the low-risk patients, over 1,000 in both studies. And we could see that the early 30-day mortality in both valve techniques were equal or even better than the surgery, and also the one-year mortality was also showing promising results. And therefore, when you look at the guidelines, the new guidelines from 2021 by the European Cardiology Society, I don't want to go through the whole process here, but what you can see is that when you have patients with aortic stenosis, you need to involve the so-called heart team. And the heart team should consist of surgeons, interventional cardiologists, and echocardiography specialists and anesthetists, and then you decide of which path is the best for your patient. And nowadays, patients that are over 75 years or are at high risk for surgery and suitable for TAVI procedure, they should go into TAVI. So patients that were typical surgery candidates are now typical TAVI patients. With younger patients below 75 years, we still go into the surgery direction. And there's, of course, patients that don't fulfill any of these criteria. And there, the heart team has to decide. So each patient in our institution undergoes a process where we sit together and talk about what is best for the patient. Now, the key for the success of the TAVI procedure is the new prosthesis, the better quality of the prosthesis, but also the better planning of TAVI patients. And the planning nowadays is mainly done by the CT. And let me guide you through the process real quickly. So what we do is we define the annulus of the valve, and here we can measure the valve, we can size it, and that kind of leads to the size of the valve we will choose. We go to the outflow tract, does it go wider or narrower? And we look at the sinus, which is important to see what happens with the leaflets, because with the TAVI procedure, the native leaflets are pushed aside, so we need enough space, especially for coronary perfusion. Then, of course, the height of the coronaries is very important because the leaflets are being pushed aside, and we don't want to occlude the ostia of the coronaries. So the width of the sinus and also the height of the coronary ostia is important. We look at the calcification. Is it symmetrical or asymmetrical? And also at the imaging plane of is it a very horizontal aorta, or is it a straight aorta, and that will also influence our implantation techniques. So these are the valves that are available on the market, the most used. There's not all of them. It's the SAPIEN platform, the core valve Evolute platform, the Accurate Neo, the Portico, Navitor, and a newer valve, or with a new revival, it's the Jena valve Geology. And all these valves have improved, and one of the big improvements was that they are supplied with a skirt around here to reduce the incidence of a paravalvular leakage. So to close the annulus completely, because paravalvular leakage was one of the biggest problem in the very beginning. The design is, there are two designs, these high frames and the low frames, and then you have here in the Portico and the SAPIEN, you have the leaflets sewed at the annular level, and there are others like the Accurate and the Evolute technique where the valves are actually sewed in a supraannular level, meaning that the valves don't take space up in the annulus but are above, and they lead to lower gradients. Now this is a kind of a typical implantation. You choose the imaging plane so that you look perpendicular to the annulus for the aiming. Then here, this is a SAPIEN valve, a balloon expandable valve. What you do fast pacing, because you want very little flow through the aortic valve, so that keeps the balloon and the valve steady. And then this is a result, a very nice height, not too deep into the LVOT. The coronaries are free, and also there is no paravalvular leakage. This is an example of an annulus that is called hostile, because there's a lot of calcification, and you have two problems. If you use, for example, a SAPIEN balloon expandable valve, you have the risk of annular rupture. If you use a self-expanding valve, the radial force might not be actually strong enough to seal this calcium, because you can imagine when the stand goes around here, they might stay a little hole and lead to regurgitation. However, because of the skirts, these problems have not overcome totally, but they have become a lot better. And even in a hostile annulus like this, we can get some very nice results with hardly any paravalvular leakage. Now let me show you some cases. This is a 76-year-old female, so young for aortic stenosis patients, severe aortic stenosis, no coronary artery disease, atrial fibrillation. There is kind of the newer scores, Euroscore and STS-PROM score. It's a low-risk patient. It's clearly normal LV function, high gradient over the aortic valve, so there is a stenosis. So when you look at the imaging, the CT, you see that the annulus is of okay, suitable size. There's a little bit of calcification, but not too much. The bulbus is large enough. There is quite some calcification, a little bit asymmetric. The non-coronary cusp seems to be involved most of the time. The imaging, the implantation angle is okay. The height of the coronaries is not generous, but okay. And when you imitate here Evolute valve, you can see that the perfusion of the coronaries should be preserved. So we look at in the heart team, what do we offer this patient? Do we offer the patient surgical aortic replacement, a MACE procedure and LLA occlusion, minimal invasive surgery, or the TAVR procedure? We said, okay, the patient is over 75. We offer her a TAVR procedure because she has permanent atrial fibrillation. She's not of especially risk of bleeding, so these two procedures are not really important for her. But what is important for her, she is not that old, so we don't want an AV block, a pacemaker, or a high rate or a large paravalvular leakage. Also, when you sit together, in these kind of younger patients, you want to be sure that the coronary access is preserved, because these patients in the long run might experience, for example, an acute coronary syndrome. And there's a study showing that after implantation of a TAVI procedure, that the cannulation of the coronary osteums can be difficult or not even achievable. And that is especially so in the high frame prosthesis and with a supraannular design. Also, because you want the orientation of the valve, how you implant it. Before, 5 years ago, it was completely random. Now we try to kind of do what we call commissural alignment, that the new commissures of the prosthesis are aligned with the native commissures. Because when the commissure of the prosthesis ends up right in front of the coronary ostium, you might not be able to actually cannulate the coronaries. Also, when you think about valve-in-valve procedure at a later stage, this design is especially bad because you can't. These valves leaflets are also pushed aside and might then later on occlude the coronaries. Also, we want to avoid AV block because a pacemaker implantation seems to go along with a worse prognosis in the long run. There are some risk factors for AV block because of the conduction system is right next to the aortic annulus, especially a pre-existing right bundle branch block is considered a high risk. Now, we have a computer program available that kind of simulates the tissue and the aortic prosthesis and calculates the risk of paravalvular leakage and AV block, and using a kind of a higher position where you go high up in the annulus, or a lower position where you go lower into the annulus, and a lower position always or most of the time goes along with a higher rate of AV block. We do conscious sedation in all these patients, and this is now the implantation of this patient. This is the root shock. We look perpendicular to the annulus. Now this is the evolute is implanted. We do a little faster pacing to keep it all at a more steady state. And this valve is good that because it's resheathable, we see that the implantation rate is a little bit low. We want a high implantation, so we resheath it a little bit, push it up a little higher, and then when we do the angio, we can see that it's very nice on the annulus, and that's the final result with no paravalvular leakage. And this patient didn't develop any AV block, which was good. And this is the final result in the CT, and the left coronary, the right coronary is here, the left coronary is here, and you see that the leaflets are aligned to the old commissures. So here is the tap, so there is a free access to the coronaries. Now, another case that I wanted to show you is a patient with a valve-in-valve procedure. It's a fairly old gentleman with a Percival valve implanted before, and that was degenerated and basically mostly because of insufficiency. And the question is, of course, what do you offer this elderly patient? There is no significant coronary artery disease. There is an intact Lima graft on the LAD, but there is still this kind of very dominant circumflex. And when you look at it, at the CT analysis, is that the valve prosthesis here, when you push the surgical valve leaflets to the side, you are at a risk of occluding the coronary ostium. And of course, that is definitely to be avoided, because once the new valve is in, it's hardly possible to get back into the ostium. So what is the solution? Do you need to reoperate this patient? No, not necessarily. There is a technique, and the technique is called the basilica technique. And what you do is you slit the leaflet that is in front of the coronary ostium here, in the middle, by 2 catheters and a wire. And when you actually then put the slit into the leaflet, the coronary that lies behind is being perfused. So this is a technique which is kind of cutting edge, and that's what we offer in our institution. We use cerebral protection because there's always a risk of some calcification to kind of leave the valve. So here we are with the catheter in the left coronary cusp. We penetrate the leaflet and we catch the wire with the snare. Then we pull the wire through, and then we have here, you have the wire in here, and then you pull and you put the slit into the leaflet. And once you've done that, you can implant the valve. And this is the new valve in the surgical valve, and you can see that it's completely free. There is no obstruction of the coronaries, and this is a very, very helpful technique for these patients. Now, there is now a dedicated device called Shortcut, where you don't have to fiddle with these wires and penetrate, but it's a special technique where you kind of have this posts and you have a little knife penetrating the leaflet, and then you pull it and you put the slit in the leaf. And we were lucky enough to do the first application in Europe the end of last year. So there is development for future for the future. Now, let me finish with aortic regurgitation, because the leaflet, the TAVR procedure, is based on that you have calcification in the annulus and on the leaflets, and that kind of is used for the valve to hook into the annulus. Usually in aortic regurgitation, you don't have a lot of calcification, and if you don't have a lot of calcification, the annulus itself doesn't really hold the valve. And there's this paper where, there's this paper where you can see that with the early generation or the new generation of devices, the need for a second valve implantation is still quite high. The residual regurgitation the degree is still quite high. The absence of device success is very high compared to aortic stenosis. And also the prognosis of the patient with a residual AR is not so good. So there's a new, more dedicated valve, and that is the Jena valve, the triology. And what it does is that there are these posts that are kind of put into the sinus, the cusp, and then the original native leaflets are in between the stent frame that's going to pop up here and these posts. And therefore, the penetration of the valve into the left ventricle is very unlikely. So there's clearly aortic insufficiency. It's a bit bright in here, but there is aortic insufficiency. And then this valve is implanted, so each of these posts is put into a cusp. And then you also do a little bit of rapid pacing, and then you release the valve, and it can't penetrate into the left ventricle, which is also always the danger in normal valve prosthesis. And so this is the final result, very nicely. So now we have a new valve available for aortic insufficiency. So let me close that TAVR is a very good, very stable method for the aortic valve. You need to look at the patient before you decide surgery or intervention, and we do that with the heart team. And we have developed in our hospital a dedicated unit with a special ward and a special cardiac doctor team and non-doctor team. And thank you very much.